Other molecular tests.
So then HER2
HER2.
becomes the big question. And I think of HER2
It's not
testing.
a breast cancer discussion, right?
Oh, thank goodness. No. But I think of HER2 as what BRAF used to be. Remember, we were concerned it was a small population of patients, worse prognosis, and so do you check BRAF, do you not? I think HER2 is sort of coming along that way. Not that it's a worse prognosis, it's a small percentage of patients, but this is a patient population that likely has another treatment option available to them. And especially with the clinical trials that are ongoing, showing response rates of 35, 40%. And when you look at the spider plots, they look very similar to immunotherapy with targeted agent combinations only.
And it's associated with resistance potentially to anti-EGFR therapy. So I think that's
important.
important.
So this is going to be my follow-up. So if I have HER2, I'm not going to give EGFR therapy?
So the original, I mean...
It's no, because I think the data would say maybe no.
Yeah,
right?
I mean, the data that was originally presented by Dr. Sienna suggests that those patients don't benefit from anti-EGFR therapy. But there's an ongoing trial for SWOG specifically in anti-EGFR naive patients. And then you get, even if you're on the control arm though, you can basically go on to the investigational arm. So that is allowed.
HER2 frequency low, higher in rectals. It gets higher, like the opposite of MSI. Do I biopsy somebody if I don't know that to see if they're HER2 positive?
I think particularly if they've been treated with EGFR therapy, there's certainly a reason that they could now have HER2 overexpression.
Yeah. So worth doing.
Absolutely.
Know it in everybody. Right, and if I
at least in refractory disease, up front, I think it's infrequent enough. Of course, if we're already doing these expanded panels anyway, we're going to have that information. But I think the key is to realize even if it's not there early, it could be there later.
Anybody care how I measure HER2?
Well, yes.
I think yes. Yeah, without a doubt.
But I would actually pause really quickly because it depends what panel you're sending off, just to make sure that the folks out there know that if you're setting a next-gen sequencing panel, you're not going to get a HER2 IHC or fishback. You'll get HER2 mutations, which is a whole other ball of wax, which is another conversation.
And less clear whether that correlates with benefit.
Correct.
Right? These studies were done with IHC fish, right?
Right,
and
not with the mutation patients. And there's some thought that the mutation patients won't benefit. But when you're ordering that test, don't think that you're just getting the HER2 with it. So make sure you order the right test. There are some out there that will do the IHC in connection with the next-gen sequencing.
So it's important, I think, just to mention that SWOG 1613 study that's brand new, that's opening up, it's specifically for overexpression. It's not for mutation.
Yeah, you have to have.
And it has to be centrally verified.
Okay, there's no study. This comes back positive. It's sitting in front of me, measured by, fish, okay? What drugs do I give? Who do I ask permission to give what drug? Single agent, combination? What are you giving if it's you?
It looks like it's a combination that you're going to need to do. You can't just do trastuzumab alone. There's two trials out there.
And not pertuzumab alone either.
Right. So you could do trastuzumab plus lapatinib or trastuzumab plus pertuzumab, both in clinical trials, one mostly in Italy, one in the US, and then I think that there's also cooperative group efforts, but it's going to be a dual blockade.
Do I have to? I'm a doctor out there. I'm busy as can be. I know that, they're going to push back. I'm scared that I won't get reimbursed for these drugs if I prescribe them, even if I've got pre-auth. Do I have to do this?
Yes.
Yes.
The response rates are high.
Yeah. I mean, that original study, I mean, the median number of prior therapies was 4 or 5.
Yeah.
I mean, the response rate of 30% was impressive, and they still had 2 CRs.
Yeah. Even risking not being reimbursed?
Yes.
Because that's a really big fear. It's a real
To live?
fear.
Yes.
Yes.
So, do you make the patient pay? If you had to pay yourself, would you pay?
For a HER2 IHC?
Yeah, no, for the test.
For the drugs?
For the drugs.
I mean, I think you have
So
to
it's-
pursue all efforts to try to get the drug.
Yeah,
I mean, in all fairness.
A lot of times those patients will be sent to us as institutions because we either will eat it or, we'll figure out how to get it
file
paid.
an appeal a second or third time.
So worth doing, everybody's saying, right?
Yeah, it's very reasonable if they're not comfortable doing to refer someplace that you may have more resources to try to get access. Right?
Might be cheaper to fly for a trial than to pay for the drug.
That's right. There are some trials out there right now where you can get access. The Colomate study has an arm in it with HER2 targeted therapy that they're flying the patients to the sites, so out there.